I'm Dr. Allan Perel, and this is Conversations in Medicine. Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine, a program brought out to talk about cutting-edge issues for the Staten Island, New York City community about medical care. We try to bring to our wonderful audience ideas of what's going on in medicine and try to take some of the mysteries out of medicine. Today's topic is hospital medicine. So many of us are afraid to go to the hospital, not knowing what the experience will be like, going into the emergency room, seeing physicians, knowing what to do, what to bring with you. And I've got three experts who actually work at the hospital. They work at Richmond University Medical Center, where I'm the chief of neurology. And it's a pleasure working with you guys on a daily basis. You guys do such a beautiful job out there that I wanted you to tell our wonderful audience and the people of Staten Island and all of New York City about the things that go on when you go to a hospital. So I'm going to go in order of beauty and age. I'm not sure which will go. But Dr. Adriana DeMarinis, who's a senior resident in internal medicine at Richmond University Medical Center. Dr. Angela Grigos, who's a Associate Program Director of Internal Medicine at Richmond University Medical Center. And Dr. Jay Fenoim, who's the Vice Chairman of the Department of Medicine, Program Director of Internal Medicine and the Internal Medicine Residency Program. And we'll talk about what residents are and how we pick all those residents. And Chief of Critical Care at the hospital. So you have the longest title. So it's a pleasure, and thank you both all for coming here today. And we're going to talk about being in the hospital. So let's get started. So, I'll ask you, when someone goes to the hospital, if someone determines at home, and again, we could talk about all the criteria medically or why someone should go to the hospital, but if someone in the family or if someone sees someone who's not doing well and it's somewhat of an urgent basis and they go to the hospital, who's the first person they see and what should they know and what should they bring? And maybe tell us a little bit about what's going on.
Sure, of course. So usually a patient that decides that they're not feeling well, the family sees that the family's not doing well, they either call 911, the ambulance brings them to the hospital, and there the EMS initially assesses them and then brings them to the hospital, and then other individuals, healthcare, the nurse triages them, looks at their vitals, what is their complaint, how are they feeling, what brought them in, essentially. And then other individuals come in, like another ER attending, and then people taking blood work. Bit.
Sure. So the triage nurse, so you walk in there, and you said if it's a 911 call, the EMTs, the emergency medical technicians, will make some assessment.
Correct.
Blood pressure, making sure that you're not bleeding,
Vitals,
and vital signs of all kinds of respiratory rate, and they bring you into the hospital. And so they used to, and you go right into the emergency room. If you come in off the street because a family member you don't feel well on your own, there's a triage nurse. What does the word triage mean? Tell us.
Yeah, sure. So a triage nurse will help to assess the acuity of the situation of how sick essentially a patient is. As we said, checking vital signs, their temperature, and what their chief complaint is. Also, the physician in the emergency department will see what level of care this patient may need. Is it a critical care ICU setting, whether they're coming in from the street or at home? And that's the way we determine who needs to be admitted or not.
So it's really how severe, how sick you are when you come in, and whether you have to be seen in 1 minute or you could be seen in a little bit more than that.
Correct.
And they all determine that part.
The triage nurse usually sees you and makes that determination very, very fast. Whether if you're having a heart attack now, you go this way. You're having a stomach virus, maybe you can wait a little bit. So they kind of determine what your acuity is and where you should go immediately, whether I should go in immediately or not.
It's interesting, we've been waiting before our show went on tonight, and as director of the stroke unit and you as the head of the critical care unit, there was a stroke code. And we made a few calls, and we had some people who were taking care of the patients in the hospital. On the stroke side, stroke is now an emergency, and people are able to be seen by the emergency room doctors within a few minutes. And it really is amazing because of all the new interventions we have, whether it's the clot busters or even the ideas that we could do thrombectomies or pulling out clots. All those things really need to be done within about 60 minutes of coming in, and that includes all the tests that people get. So it's really remarkable what they're able to do, what we're able to do, and really having an emergency room, work quickly.
Right.
So let's assume someone needs to come into the hospital. The reason I have you guys here is that you work really more upstairs, we say. In the emergency room, there's a whole department, and we've done television shows about the emergency room staff and what they do, and their training and their expertise, and that they know a lot about a lot of things. Now, if someone gets admitted to the hospital, tell us what it means. Maybe I'll talk to Dr. Fernand. What is a teaching hospital?
A teaching hospital is it's a hospital that has the tripartite goal. 1, clinical care, 2, education, and 3, research. It so happens that there are just about not up to 10% of the hospitals in the United States meet that criteria. Most of our patients really do receive care from community hospitals. Rumsey happens to be what I call an academic medical center. You do have clinical education and patient care. You have education of residents. You have medical students coming through as well, and there is some research.
So what do you guys think? So some of the major hospitals in the country, Mayo Clinic, Columbia Presbyterian, NYU, Hopkins, we can mention names all over, are really very academic hospitals. The reason all the research comes out of much of the research comes out of those hospitals, because they do research. Now, if a person goes into the hospital and one of the people they see is a resident, and I know you're a resident, you're a senior resident, and there used to be all kinds of words, and there still are. We use the word intern, and intern meant that you were interned at the hospital many years ago, even before my day, where people used to live in the hospital and just be let out occasionally. And resident meant you were in the hospital, but you were able to get out a little bit more. What do you think about when you have a patient that comes in that's assigned to you? What are the family's relationship with you, and how do you take care of them?
Absolutely. So as a resident, we always introduce ourselves and make sure that they know our title in the hospital and that we are under the supervision of our attendings. We're very fortunate at Richmond University Medical Center to be able to have the ability to interview patients, to treat patients, and be under the supervision of an attending to guide us after we give,
Let's
what
use some
we've
words.
learned.
I'm going to actually interrupt you. Is a resident a doctor?
Yes, a resident is a doctor.
So it's a medical doctor?
It's a medical doctor that has not yet achieved their full medical training yet or is board certified. So we graduated medical school, we passed board exams, but not our licensing board exam, which we take at the end of our third year of residency training. And when we do discuss cases with our attendings.
And what's an attending?
And so an attending would be a board certified attending that needs to keep up with the updates as a resident of course does as well, and is credentialed in specific fields, whether it be ICU, a gastroenterologist, and they're able to guide our care and our treatment and agree with our plan of care for the patient.
So they're the more senior with regard to years of doing things. Tell us what a hospitalist is. So right now, it's interesting. In years ago, when you go to the hospital, you'd see your regular medical doctor. They'd make rounds in the morning or rounds late at night. And they'd go away. They'd go back to their office, and then we'd see their patients and come in. Over the last 10 to 20 years, many of the hospitals around the country have gone to a concept of a hospitalist. Tell us what a hospitalist is, and should someone be concerned, say, if Dr. Smith is your regular doctor, and should they be upset Dr. Smith's not seeing them in the hospital, and somebody else, like Dr. Grigos, is actually seeing them in the hospital? And how do you reassure them, and what do you say?
Of course. So a hospitalist is one who mainly practices in the inpatient. They're employed usually by the hospital as well, and so they see only patients in there, and then they take care of the patient throughout their stay, from the moment they are admitted to the moment of their discharge. A lot of times there is a challenge with not having Dr. Smith from outpatient come in and take care of the patient, but we are sure that they get the same care, the best care. And also it helps that we communicate with that outside attending as well, so that we assure the patient that we know the care and that we could provide whatever medical care they necessitate during the time.
And hospitalists are in the hospital all day?
All day.
And there are people covering almost 24/7 for that whole process.
Correct. Throughout the weekend, holidays, so there's no lapse in time. So that, for example, Dr. Smith is taking care of his outpatient clinic. During those 6 hours that they're busy with that, there is someone there taking care of them in the inpatient to
And
meet their needs, to follow up with results, to address things immediately.
tell me about testing. When people go into the hospital, there's always the concern, is the test being done quickly? Is it being read quickly? I mean, as attendings, as senior attendings and residents, we're always concerned about, we want the results now. And that's sort of our society, and that's what we do. How do hospitalists and how do residents, how do they figure out how to get these tests done as expeditiously as they can? Tell me.
Sure. So, of course, we try to figure out what is the most important test that needs to be done during a hospital stay. And we contact by ways of communication, because communication is key, especially in our hospital. We have a good rapport with the radiology staffs, and if there is holdup, we communicate this with the patients. A lot of tests, though, fortunately, could be done as outpatient, and we could have scheduled times, and we could prevent that delay in any of the testing that really doesn't need to be done as inpatient, that could actually wait as an outpatient. So that's one thing that we could do.
Jay, tell me a little bit, as a good friend of mine, with regard to efficiency, not even efficiency, how long people stay in the hospital. What are the goals as an administrator, someone who's running much of the program? What are the goals about people going home, and how can you get them home soon?
Yeah, we would like people to come into the hospital if they have to be in the hospital, and to get out of the hospital as fast as early as they can. The hospital really is not a place to be if you don't have to. The longer you stay in the hospital, the more likely you might pick up another infection. There's a possibility that you might have even falls. A lot of things can go wrong. So we try to get patients in as quickly as get patients in and out as quickly and safe as it can. As we can. As a matter of fact, there are occasions where we even transition patients through short-term rehab and other places just so they don't stay in the hospital.
And it's interesting, as a neurologist, we see so many patients who have some type of cognitive impairment, whether it's dementia or even just age-related cognitive impairment. And when they go to the hospital, they become more confused. And it's very obvious why, because they don't know where the bathroom is. They don't know where their silverware is. They don't know where their clothes are. So when they get up at 2 in the morning, they're not sure where they are, and they look much more confused. So our goal is always to get people back home as quickly as possible. So I'm going to ask you a question that I didn't even think about before, but I'll say it now. As head of the intensive care units, the critical care units, people always are wondering, how is someone determined to be in an intensive care unit?
Yeah, we determine it by the acuity, how sick you are, and the probability that what you have, the likelihood that what you have can result in death or other disability. Say you come in and you have a heart attack, the likelihood that you can get complications from that is very high, so take you into the coronary care unit. If you come in and your blood pressure is low from an infection, you're more likely not to do well, so you get taken to an intensive care unit where you can be observed more, the intensity of therapy treatment is higher, and that's how we determine how patients get into the ICU.
So tell me, when people go to the ICU, I mean, I think what I always found so interesting when I look at some of when you go to the hospital, a lot of how people do is based on nursing care. And nursing ratios and how many nurses per patient there is.
You're very right. At Ramsey, we have in the ICU we have 2 nurses per patient, 2 patients for each nurse in the intensive care unit. It does help a lot with the patient outcomes, as studies have shown, and that's what is required. There's a lot of work that goes into taking care of these patients in the ICU. And you're right, the nurses, while you have doctors in there, the nurses are those at the bedside who are always informing us of what's going on, because you have 1 doctor or 2 doctors and maybe 10 patients. You can't see each of them continuously. The nurses do at the bedside, and they inform you of what's going on.
And that's the truth of all specialty care. When so many patients want to go to a place where they only do hip surgery, or they only see stroke patients, we have a stroke unit or an intensive care unit. Well, one of the things that always leads to better outcomes is really the number of nurses and how educated the nurses are to watch you in case there's any changes. Well, we have a stroke unit right now that has a 1-to-4 ratio, which is not exactly like the ICU, but clearly better than the numbers on the floor. And that's been shown to have people do better, have better long-term outcomes, get out of the hospital quicker with less complications. So that's what's so important. So I'm going to go into a little different topic. Tell me about medical students. Not every hospital has medical students. We have medical students. We have a lot of medical students from all over the world who come to our center. And they learn, and they're wonderful, they're bright, they're inquisitive. They keep senior attendings on their toes. They keep residents on their toes, because they ask questions that you sometimes wouldn't think they would ask. So they really make rounds, which means going around the hospital, very, very interesting. So tell me, do you think patients are sometimes concerned that someone is experimenting on them, that a medical student who has really no expertise in the field is looking at them? What do you say? I mean, any of you guys, what do you say when a family says, I don't want my relative seen by a medical student? And is there anything that you encourage? Because again, we always want to teach, but we also don't want to infringe upon what they want. So tell me.
It's important for them to know that we're a teaching institution, Richmond University, and we encourage learners, medical students, residents, and it's an environment for learning and teaching. And that although the patient is an opportunity for them to teach the learner as well by what their medical condition is, and that in itself is a privilege for the learner and for the patient, I think, to find something more. Like maybe the learner will ask more that the resident didn't have time to ask, or the attending didn't, and so sometimes that creates a nice relationship as well. Of course, if they don't want the learner there, that's their choice.
There's always their option not to have them.
Of course, yeah.
So tell me, Jim, what do you, when you have medical students, and you really work with them much closer, even though they come on rounds with us.
Absolutely.
There's always that step. So the students learn from the residents, and the residents learn from the attendings, and that's how it always worked. So tell me, what do you think of students?
So I think students are a great asset to Richmond University Medical Center. They help the patients with, when at first initially, patients may be a little hesitant. They're still in medical school. They haven't yet passed some of their exams. They may not be as knowledgeable in the field as our attendings and whatnot. But a lot of patients are very receptive, and medical students will go out of their way, and it could be as simple as, may I have a cup of water with ice? The nurses may be busy with other patients, and the medical students will go ahead and even explain the side effects of certain medications that they may be concerned about with the help of their resident. The key thing is having an open dialogue and an open conversation with patients, and make them aware that they know who each individual is standing at the bedside, because it is quite intimidating when you come into a hospital, when you see an entourage of people coming into their room. So it's nice to know who, what role everyone plays.
And I think it's very important. And there's been more times than I could even ever imagine where a medical student has told me something about the patient that I didn't know.
Absolutely.
When you have so much time to spend with the patient, you hear sometimes some tidbits that really are crucial. Somebody happened to go on a trip to Thailand and we didn't know about it 3 years ago, and it turns out to be the key part to the case. So sometimes when you watch television shows like Dr. House, there's even the medical students come in.
And I think one of the important things to remember is, like Adriana mentioned, be open. Everybody at the bedside, this is a medical student, this is a medical student's role, this is an intern's role. If you introduce yourself and your role, most of the times the patients are very, very receptive.
Tell me about physicians extenders, the
Yes.
concept of nurse practitioners, physician's assistants. There are many in the emergency room, all throughout the hospital we see people. And I think part of it, I'm not sure if I'm not even sure if in the ideal world having a very senior attending work 24-hour shifts would actually get the same service that people who know what to do in the middle of the night. Sometimes you need the people who know if there's a problem at night what to do. And I haven't done certain things in many years since medical school. So the idea of what I would do at 2 o'clock in the morning if someone had a problem, clearly you guys know a lot more, the residents know a lot more about what to do. But what do you think, and if, should people be hesitant about seeing a physician's assistant and a nurse practitioner in combination with the healthcare team? Maybe
No,
Tom.
they shouldn't, because these are well-trained individuals as well, and most of the time they're working under the supervision of an attending physician who is directing the care. They train, some of them have subspecialties, and they should not be worried, as somebody's looking over the care as well. And I said they're well-trained individuals.
And it's a necessity of life. I mean,
Yeah.
that's one of the things that
Yeah,
we actually do
yeah.
see. Let's go into a little different topic. Tell me about visiting hours. Everybody goes to the hospital. If someone's in the hospital, goes to visit. Nobody knows what time to come. Nobody knows whether you're bothering someone. Nobody knows whether the nurse needs you out of the room. How do we make people comfortable visiting? Because it's very nice to have visitors, but the idea of having 20 visitors around someone who needs some rest is not good either. How do you guys decide that in the hospital? You're there all day, the nurses are there. The residents don't make the decision as much. Well, that's the attendings. What do
Yeah.
you guys do? How do you decide?
I encourage my patients to have their family at bedside. I think it helps, one, make the patient more comfortable, and then I think it helps with the care because, and then the family is also another advocate for them. Also,
Meaning that if someone's not feeling well,
Correct.
or they're frustrated they didn't get a test, or their breakfast didn't come, or something's a little late, yeah.
they're there for them.
Right.
And sometimes even language is a barrier for the patient, so they have their family member talk for them. Also, I find they can come at any time. It's 24 hours. They could stay at the bedside of the patient. I mean, we're very,
So someone works a day shift,
they can come at night
they could come
and
anytime.
stay at the bedside all night, sleep, I guess, in a recliner or chair.
And
by
that's
the
different
family.
hospitals. I want to say this is, at least for our hospital
For
that
our
we know.
hospital.
But in every hospital, and I think, Jay, you were talking about there's a trend towards that happening.
Yeah, it's been the trend has been going on for a while. In the past, people had restricted hours to visit, but right now, open visiting hours has been shown to improve patients' outcome, patient satisfaction, and a lot of other factors that we take into consideration as far as patients' well-being is.
So just having you guys here, so anything that comes into my mind, I'll say. So you guys run a residency program, and medical students from all over the, as I said, world come to our hospital and go all over. You guys decide who's going to come in. Not everyone decides. These two on that. So how do you decide about who comes in? I mean, we have a lot of people out there. We have a wonderful audience. People have relatives in college, relatives in medical school, all over the country, all over the world. And sometimes, even if you go in as a patient, you sort of say, is that person I'm seeing who's in training, is that the person who really should be here? Do they care about me? Do they not? How do people pick residents and who should be in the hospital?
Oh, that is fairly challenging, but we do the best we can. How intelligent an individual, all these young doctors are fairly intelligent, they've passed their exams, will have their scores, so it's not a matter of whether they're intelligent or not. The one thing that we really look at is how they rate as far as compassion is concerned. How they rate as far as compassion is concerned makes a very big difference in whether they come into the program or not. And the other thing we do, which I mentioned, is our institution, as other institutions, we want people, young people in the community to be able to come to the program. So we give we give some preference as well to the local candidates, because we want people to stay in the community, and those are the people who are more likely to stay. Yeah.
So again, what we try to do is choose, of course, from a very bright group of people who've passed all their tests, but it's just so important that you are able to communicate with patients, work with others, be compassionate. I mean, the concept of why people go in to be physicians, is always a difficult question when you ask. But the idea is you have to take care of, you have to be with patients. And you really can be the smartest person in the world, but if you really can't talk to someone or interact with your colleagues, it really doesn't work.
Right.
Tell me about discharge planning. So when someone's in the hospital, part of the thing very early on is we want to know when you're going to go home. So I'll talk about it from a stroke point of view as director of the stroke unit. If someone comes in, I have a pretty good idea. One of two things will happen. Either they can go home or they can go to a short-term rehab center to get better. And I could tell basically by their deficit if they've had speech problems, if they have weakness, if they can't walk. And some of the things that I learned, and I'm married to a social worker, and we met actually at the hospital, it was over a few patients that we had discussed many years ago, is the idea of someone who lives in a walk-up house, there was no way they were getting home. And I was being so, I'm a new attending, I'm a neurologist, this person doesn't look too bad. And she said to me, unless you carry them up the stairs, they're not going to be able to walk up the 25 steps they have. There's no elevator. So the idea of the discharge planning people is so important. And it's not just to, quote, get people out. It's not just because of things. We want people to be safe and healthy and able to go different places. So tell us a little about discharge planning, whoever likes
I mean,
to.
I think discharge plan has to do more with the transitions of care. A lot can go wrong with, with somebody leaving the hospital. So it's good to have the discharge planning. They know what you need, anticipate what your needs are going to be when you leave the hospital, and start making arrangements. Like we're talking about patients who have strokes, physical therapy sees you, discharge planning sees you as well, and they start making arrangements for short-term rehab if you need that. So it has to do more transition of care and safe discharge.
So we're coming up to our last couple of minutes. And if there's something that you could tell our audience, and I'll let you talk to me or you can talk right to the camera, is there anything to make them feel comfortable about going to the hospital? Sometimes the idea of going to a hospital is very scary, especially for children, especially for older patients. And maybe I'll start with Adrienne as a resident. Is there anything that would make people feel more comfortable with the
Sure. So in our hospital, we always try to welcome our patients. I know they are very scared. It's a nerve-wracking time. They're waiting for exams, and when you come to the bedside, you are their link between what their questions are, and you want to provide the answers for them. Well, what I could say is when you come to a hospital, be prepared, answer questions freely and openly. We want to help you as much as we can and do what's in the best interest of our patients. We take an oath when we graduate medical school, and I'll never forget the day I took my oath. And first thing is, first do no harm. And that's essentially our motto that we follow at our hospital, and I pride on that. And I think it's important for our patients to know to feel comfortable and at ease when they come to our hospital.
And you said something so wonderful, that be honest. If you take in a medicine, taking something that's not, everything is confidential. Something that's legal, something that's not legal. It's very, very crucial to say it. If you don't, then we live in a mystery box, and we really have a problem with that. So it's very, very important to be honest and open with your doctors, because there's something called HIPAA, where nothing that's said can leave the area. So our half hour's up, and I wish everyone could say it, but you guys represent the hospital in such a fine way. It's a pleasure working with you. And there's one thing that we always say is communication. It's that the medical student and the residents and the attendings and all the people really should be able to talk to each other to get the best care for people. And hopefully we're really on the cutting edge of doing that with some of the new things that we're doing. So thank you all for coming.
Thank you.
Thank you very much.
Thank you so
Alan.
much.
Thank you.